Good morning and welcome to our Health Foundation webinar on implementing innovation, how we make real the promise of new technologies. My name is Malte Gerhold. I'm the Director of Innovation and Improvement at the Health Foundation, and I'll be your host for this webinar. Thank you for joining us this morning for the next hour and 15 minutes until 12 o'clock. Please note that this event is being recorded and the video will be available on our website afterwards for 24 hours. And at a later point, we'll also make available a subtitled version. Today, we have a fantastic lineup of speakers joining me, so let me introduce them. First of all, a special welcome and good evening to Jean-Frédéric Levesque, who's joining us from Australia, where it is rather late in the day already, so I'm particularly grateful for you being able to join us. Jean-Frédéric is the Chief Executive of the Agency for Clinical Innovation in New South Wales, which we're going to hear more about in a moment. And prior to that, he held a series of senior roles in the health system in Canada. Next, a huge welcome to Catherine Ward, who is the Chief Commercial Officer and Managing Director for UK and Europe for Healthy.io, a digital healthcare startup. And Catherine's career before that also includes many years, both in the NHS and in the private sector. Third, also pleased that Sultan Mahmood is able to join us, who is Director of Healthcare for BT Enterprise, obviously a large partner for the NHS, and who has joined BT from his previous role as Chief of Innovation, Integration and Research at Royal Wolverhampton NHS Trust. And last but not least, also thank you for joining us, Chris Lang, who's the Chief Executive Officer of UCL Partners, which amongst other things hosts the Academic Health Science Centre and Academic Health Science Network in North and East London and beyond, and who's also a practicing consultant at University College London Hospitals and Royal Free Hospitals. Thank you so much to all of you for joining us today for this webinar. So let me do a short introduction before we go ahead. Today's webinar is about implementing innovation. Now, we all know why innovation matters. We've got the ongoing demand, we've got workforce pressures, and new technologies and innovation are being looked at as one critical component to help us transform health and care and improve the experience for patients and staff alongside that, and make our systems more sustainable for the future. So quite a lot of expectations. Now, over the last few years, including during the pandemic, we have seen a growing success for bringing innovations into the NHS, including through support to startups and technology businesses and working with the NHS, and also better piloting and evidence generation for new approaches. However, despite this, I think we know that we're not yet great at the wide-scale implementation of innovations that we have found to work across the NHS. And it is this gap, that of spread and implementation, that we will focus our discussion on today. Indeed, as many of you will know, it's an area of long-standing interest for the Health Foundation. Back in 2018, we published a report titled The Spread Challenge to set out an approach to better adoption and spread. And last year, we did an analysis of 31 innovation programs across the NHS that offered funding for innovation, from where we saw that 22 of them offered support for innovators, but only 4 offered support for adopters of innovation, and then a small handful did both. So the topic of implementation and adoption remains a very live one today. Now, there's many barriers to implementation that are well known. They include challenges of sustainable funding to health and care services, of the right workforce capacity, and of addressing the operational pressures arising from both for staff providing health and care. There are also known barriers around regulations and the wider incentives from payment and policy approaches across the NHS. Now, for the purposes of this webinar, I'd like to acknowledge those challenges and pressures, but not address them further in detail. Instead, my question to our speakers is going to be what local and regional leaders can concretely do today about the capabilities and partnerships that we need to better enable implementation and spread of innovations today. So, to give you a short overview of how we're going to spend the rest of our time, for the first 10 minutes, we're going to hear from Jean-Frédéric Levesque about his experience from the Agency for Clinical Innovation in New South Wales. And after that, I will ask Catherine, Sultan, and Chris to respond with their own reflections on what they heard and what we can learn for the NHS from that. We're then going to move into a wider conversation and also take questions from you, our audience. If you have questions, please put them into the Q&A box, the chat function on Zoom at the bottom of your screen. You can submit them at any time. Within that, you can also upvote questions which you'd like to see answered by us so that I can pick them up for the discussion later. I will try to answer as many questions as I can, but of course there will be a bit of a limit on our time for that. Also to thank everyone who submitted questions in advance, which I'll also draw on for the discussion. And if you want to tweet about this discussion as we're going live, please use the hashtag implementing innovation. Right, with that out of the way, let us begin. Jean-Frédéric, over to you. Really excited to hear about your experience.
Thank you, Malte. I'm going to load the presentation. If you can just confirm that you can see it in full slide, that'd be great. Is it working?
It's not come up yet.
Oh. I think it should be okay now.
There, it's coming. Yep. If you just make the slides full screen, great.
Here
Perfect.
you go.
We can actually see your, yeah, there we go. Perfect.
Sounds good. Thanks,
good.
and thank you so much for the opportunity to briefly talk about our experience. I'll go quickly, and I'll be very happy to share any slides afterwards. If people are interested in looking at some of the frameworks that I'll talk about in more details. Before I go any further, I really want to acknowledge the traditional custodians of the lands from which I'm working today and talking to you about, and really recognize the contribution of indigenous populations around the world, and also to recognize and appreciate the consumers that are participating in our work, and really emphasize how vital listening to consumers as part of innovation work really helps us to make a significant health system change. I just wanted to start with this quote, really, that highlights our vision to create the future of healthcare and healthier futures for the people of New South Wales, but really state in brief terms the role of the Agency for Clinical Innovation. And really, as you can see there, we're the lead agency for innovation in clinical care. And the really value-add contribution that we make is to bring together patients, clinicians, managers to support design and implementation of innovation in healthcare. And that's really our mandate within the New South Wales health system. The agency has existed now in its current form for 12 years, but we've got in many of our clinical networks more than 20 years of experience. Just a quick slide to say that obviously we're only one organization of the New South Wales health system. What you can see there at the top are the Minister's Secretary and Ministry of Health. In the middle, local health districts, which really are leading the service delivery in the state. On the left, statewide health services and shared services. And these are organizations that we work really closely in partnership with, especially with regards to e-health, health infrastructure, New South Wales pathology, for example. And on the right, you can see the pillars of our system, and the Agency for Clinical Innovation is one of those pillars. And we work very closely with the Bureau of Health Information, the Clinical Excellence Commission, Cancer Institute, and Health Education and Training. And therefore, what I'll talk about today and the two statewide implementation programs that I'll mention really have been supported by this entire ecosystem. And I'll just briefly reflect on one key enabler of bringing all of these together so that we've got a really truly aligned system trying to mobilize the different expertise that are required to create system change in New South Wales. Within the agency, I just wanted to flag that we are combining four types of expertise that are really crucial to innovation, redesign of healthcare, and implementation. And the first one on the top right is the engagement expertise. You know, we've got communities of practice, clinical networks, consumer engagement processes, international experts involvement, really so that we create a movement behind a lot of the innovations we want to promote and implement. We need evidence expertise, and that really means academic research, but also empirical data about what's happening in New South Wales, gathering the experiential insights from clinicians and consumers, and very rapid evaluation cycles to help us progress some of the innovation that we want to implement. We need change expertise, and we have those experts internally in terms of redesign, co-design, implementation support, and also not to be forgotten, the communication expertise, because a lot of system change at the and implementation at the system level does require actually to persuade people to do things differently, or persuade people that they need to invest differently or change some regulations that may be barriers to innovation. And at the ACI, basically, we're the organization that combines those different types of expertise for the purpose of catalyzing innovation in the system. I'm just going to briefly talk about various types of methods that we're using to promote innovation. And that's a framework where you can see that we're really working a lot on executive level engagement. That's the outer circle. Program level engagement, in creating also project and clinical leadership expertise, and then at the bedside, really embedding clinical initiative in partnership with patients and carers. And to give a few examples, we do use a lot of strategic system-wide executive sponsorship and spend a lot of time making sure that we've got the commitment of various leaders. And also we've spent years in creating a community of practice of leaders, people that are now my colleagues really, and I can work with to implement change at the system level. We put in place internal governance structures and put in place program and clinical leads in local health systems so that we've got really a little army of people on the ground that can mobilize further clinicians in hospitals and in different regions. Access to data, virtual care technologies, redesign and improvement skills are extremely important to create that capability at the local level, so that people can actually implement things that are quite complex and quite complicated with the right tools. And we do invest a lot in communities of practice and also the use of vignettes so that we inform people about what are the successes that certain local health systems have been able to achieve and what are the recipes that they've taken to achieve those. And then at the really clinical level, we've got a variety of tools that we use, such as audit and feedback, to really provide people back their own information and data, peer mentoring, education, redesign, and we use a lot patient-reported measures as a way to drive change, increasingly, really making sure that we give voice to patients in terms of the outcomes achieved through the innovations that we're promoting. So the first example that really I wanted to talk about was this New South Wales telestroke service that we've implemented over the last 2.5 years. This is something that we started in 2017. We piloted telestroke in 2 local health districts and then gradually evaluated and demonstrated its potential effectiveness, created a business case for Treasury, to generate, the significant investments required, and then got on to scaling the program, developing the models of care, and providing implementation support in a wave of implementation that have taken us now 2.5 years to implement in 16 different regions in the state. And really, this has brought in 23 rural and regional hospitals services that were not there before. It did include a lot of implementation support as listed there, as well as technological upgrades to really be sure that we could actually change the model of care in a safe and efficient way, even in very remote communities in New South Wales. As you can see there, some of the elements of statewide implementation that I just talked about have been organized for telestroke implementation into 3 main phases. And the first one was the planning, where you can see, tasks like really providing a good understanding of what the telestroke service will be, with clear models of care very well established, the education and implementation, etc. Then we would assess local communities, local hospitals for readiness for change, do a gap analysis, really look at the structures and sequence that are required to implement the solution so that we address the local gaps, and then identify the dependencies with regards to information technology, really making the local system ready for the innovation that we were about to implement there. And finally, a stage of operationalization. What I wanted to flag here is that really, again, this has been a collaboration between the Agency for Clinical Innovation eHealth, the Ministry of Health, and local health districts. And the emphasis or effort required by different organizations did vary across the different stages of implementation of that program. And creating that synergy between those central agencies was absolutely fundamental to implement such complex changes. The other program where we implemented something similar and are in the middle really of implementation, having starting 2 years ago, is our patient-reported outcome measures program, where we are now implementing a technology platform where patients can answer different quality of life indices at a distance, and clinicians use it in clinical practice. And what we're doing there is a similar kind of staged implementation, which really requires not just to embed the technology into local system, but also to think about what are the changes to those local systems that, again, need to be made ahead of time so that those clinics are ready for the new system. So just to share some key lessons from our statewide implementation efforts, and I'm just giving today 2 examples, but there are some others. The first one is really that you need to build on executive partnerships. I have been in New South Wales now after moving from Canada for 10 years, and I've been going to a senior executive forum every month for 10 years where I meet with my chief executive colleagues from local districts and other organizations. And also once a month, I meet with eHealth and other pillar partners in the system strategy group, really creating that connection to ensure that the system works as one. We need to harness the local ecosystem for innovation. Different organizations really have different aspects to contribute, and the Agency for Clinical Innovation can only do its bit, its own value add. And by being the catalyst of the ministry, pillar organizations, and local health districts working together, we can really accelerate and bring at scale some of the changes we want to see happen. The pipeline management is very important, and I'll just very quickly show here that we are increasingly implementing this pipeline to make sure that we don't just do a lot of grassroots innovations that you can see on the left-hand side there, but that we gradually, through rapid evaluations, pilot testing, securing additional funding, we bring them to be bigger programs until they become large-scale implementation programs. That really means that we need to plan at times a few months or years ahead of time when we're actually piloting something, planning what will be required to bring it to scale, and not wait for the final evaluations to be published to then think about how will I bring this to scale, because it does take time to mobilize all the stakeholders towards large-scale implementation. The fourth lessons for us was really to try to align various levers for change. We all invest a lot in telling people what would be the right change and what they could do differently, and that's the cognitive lever. But there are many different levers that we need to align for statewide implementation. And again, I'll refer the participants to that framework that we've published in 2019. But just in summary, we need to combine supportive lever, formative levers, training people, the mimetic lever, that really means showing that other people are actually implementing the innovation and are achieving some successes through that. And then, even though we don't often at the Agency for Clinical Innovation control the levers that we see on the right-hand side of that graph, more coercive lever, either financial or regulatory, normative levers that relate to the work of professional colleges, for example, structural levers that relate to capital investments, or the competitive levers that are happening in the market. We even though we don't control those levers, it's important to understand what's going to be their impact on the programs we're trying to implement at scale, and really trying to partner with stakeholders that are controlling those levers so that we align as much as possible is really, really key. Standardized guidelines and localized implementation approaches are very important. It's not just about the standardized guidelines, it's also about making sure that when we approach local districts to implement, we don't necessarily come with a single method. And there's a lot of different organizations trying to push very specific methods. One of our lessons is that it's important to have a toolkit of implementation methods and really try to find out what's the one that will be the most acceptable to local areas and the one that will take them on the journey for change. So a toolbox of implementation and adoption methods is very important. Local sponsorship and dedicated local implementation resources is very important, and therefore a lot of the funding that we receive when we do bid to treasuries do include funding for local hospitals to have an anchor, to have someone dedicated to a program, really able to push for a period of 12 to 18 months and being the relay for our implementation programs. And finally, remember that implementation takes longer and more resources than anticipated. It's always the case. You need to have contingencies and also options to extend certain phases of implementation at times. And if the funding is all too tight to specific steps, you may end up not being able to achieve some of the milestones that are required to go further. On this, I'll just finish, Malte, by saying that at the agency, we also try increasingly to go towards more transformational changes, change that is really new and disruptive in terms of the delivery model. But the reality is that you cannot afford to conduct many implementation of truly transformational programs all at the same time. You need a portfolio which is balanced, where quite a lot of optimization programs are in place. Quite a lot of adjacent innovations are being established within existing systems so that you can dedicate the amount and intensity of resources required for the ones that are truly transformational. And that's certainly the last lesson I just wanted to share. Really not trying to tackle too many transformative changes all at the same time, and really building on the goodwill and the relationships that the core and adjacent innovations, which are a bigger piece of our work, really, to build on this when the time comes to be more transformational. So on this, I'll stop there. Malte, I hope I was able to not take too long.
Thank you very much for sharing your experience, Jean-Frédéric. Really insightful. If I pull out a few of the things, for me, from what you said, I think there was a lot around the dedicated expertise and capacity available from the agency for local partners for implementation in terms of change expertise, but also around aspects of communication and building a coalition and commitment. You talked around the coordination amongst senior stakeholders, alongside building the clinical networks locally for the implementation and bringing staff and clinicians together. You talked about having a toolbox available for localizing the approaches that you take, and then also about the commitment and persistence to a small number of truly transformational issues alongside a wider range of smaller aspects of optimizing processes that exist. But before I start and take the thunder of our panelists around that, if it's okay.
You've captured it very well. Thank you.
Yeah, thank you. Sultan, if I may come to you first of all, if you share a bit from your own experience working in the NHS, but also now with the NHS, and also from what you've heard from Jean-Frédéric, what you think might be translatable to our NHS context in the UK.
Okay, yes, I think first of all, I'd want to thank Jean-Frédéric for a very authoritative exposition of what innovation in healthcare requires, and some standouts for me was the relationship word you mentioned, Jean-Frédéric, and how important that is to do this, because this is really complex, wicked problems that we're trying to address. The influencing levers you talked about, and also you acknowledged that it takes an awful long time, and that's the reality in which we have to deal with. The second acknowledgement, Malte, I just want to kind of acknowledge our NHS colleagues up and down the country who are operating in the most difficult of circumstances at the moment. We are all aware of the black alerts and things that are going on, and it's incredibly tough. Yet in that space, we're asking people to kind of split screen, which is the kind of the buzz phrase, as in kind of focus on the problems of today and focus on the problems of tomorrow as well. And it's a must. And my own experience of a quarter of a century in the NHS, and now for a big company like BT, it's really a bit of an extrapolation around what Jean-Frédéric talked about. So the first thing I would say, in the world that we are in, I think Ben Goldacre has kind of really set it out very, very powerfully in the Goldacre report around, we must get the kind of data, if you like, the data architecture, data infrastructure, the whole data play. Yeah, we've got to get that right, because if you're thinking about our populations, yeah, increasingly complex, multi-morbid, kind of falling between the transitions of care and then kind of repeating demand cycles, they don't sit in lovely pathway diagrams. They're incredibly complex and move about the system in a complex way. And again, how do you kind of match your innovation to kind of manage that cohort, manage their illness and manage their wellness? Because, you know, the NHS really needs to move to from a sickness service to a wellness service. And I think getting the data right. So, and I'm all for kind of agnostic platforms that aggregate and build on ecosystems that operate well within health economies and allow the kind of free movement of data for clinicians and carers to do something anticipatory, yeah, before somebody goes off. That's the first thing, getting the data right. And I know there's a national data platform in the background that's kind of being worked through. There's kind of TREs, there's kind of secure data environments. All of that needs to be kind of brought to bear. And that, as Jean-Frédéric has kind of said, that takes time. But while the kind of macro kind of policy drivers are kind of worked through, and then there are challenges and opportunities around that, what needs to happen? So I think for me, my personal experience of this over a long period of time is the analysis of the complexity of the scenario. So kind of, we're talking about complex care cohorts as an example, so multi-morbid patients. What is going on with those people's lives and the care that they receive? What's happening in their transitions? Yeah, and I think to do that really well in the programs that I've kind of read about or I've kind of participated in, having, you know, clinicians particularly who are interested in this, giving them the kind of time in their job plans to really think through the problems and plan to innovate and plan to fail on occasion is really important. Job plans are really, really difficult. But I think we need to kind of, you know, think about how clinicians get the time, because, you know, we have some of the finest clinicians in the world, and we perhaps don't give them the time to kind of analyze the complexity with a good PMO function. I think the second thing is, from my own personal experiences, this is the care cohort is really important. So what is the specific problem that you're trying to address? Yeah, because innovation can be simple or incredibly complex. And the translatability and scaling of that will be kind of predicated on the quality of thinking around the care cohort. The leadership culture. So the organizations that really do well, you know, Jean-Frédéric mentioned some in New South Wales, right? In England and in Wales and Scotland, Northern Ireland, you know, kind of, there are some amazing pockets and we all know them, we can quote them, and it'd be unfair to kind of pick on one or two, yeah? But you'll notice something about their leadership culture, because the money's never going to be enough. We never will have enough money or enough people, yeah? But those leadership cultures create spaces for people to do this work and create air cover for people to kind of make mistakes if necessary to learn. And their staff engagement seems to be better and their general operational processes seem to be better. So the kind of staff engagement and leadership culture is so important. So Jean-Frédéric's point about senior sponsorship is so crucial. I can't emphasize this enough. You know, we know the leaders in the NHS that have kind of stood the test of time and managed to kind of innovate in difficult cycles. And again, and the last point I'll make without kind of blathering on is this requires two kind of parallel swim lanes, really, for me, in my experience. So you need somebody to be a champion or a group of people to be real champions. So that social movement piece is really needed. So, you know, I go back to the data. Care data in the UK was a, you know, dog's breakfast. And why was that? Because we lost the pub conversation. We lost the pub conversation with the punters. And now, if we're going to do something interesting with data and care and kind of manage people proactively, I think we need to be really honest with people and kind of say, look, if we were to kind of share your data in a way that works for you and your carer, we might be able to give you better care, less visits to X, Y, and Z, kind of a better standard service, and we might be able to do something on a proactive basis. And I think parallel to all the policy stuff, the big conversation around data. And I think big companies like BT, who are kind of, in 34 million homes or whatever it is, have responsibility to kind of engage in that with the rest of kind of UK PLC and say, right, how do we kind of engage our population, the people we serve, around the data? And then really, and John Frederick said this much better than me, there are lots of kind of influencing levers that need to be kind of almost kind of interacting on a parallel basis. So really strong program management. And again, I think one of the issues I see in the NHS now, and it's exacerbated, is that we're losing quite a lot of good people who are skilled in kind of health tech innovation and kind of implementation, and we're losing it to other sectors. To build up this kind of profession, the core group of CIOs and their kind of teams, we've got to kind of match the commercial sector in terms of skill and kind of development opportunity. And the parity of esteem, for me, doesn't appear to be there. So we give a lot of kudos, quite rightly, to CNOs and Qs and CMOs, yeah. But I think CIOs and the kind of information digital community within the NHS, I think, really need a kind of some help with recognition, and kind of their job is to be a bridge between the two worlds. And I'll stop.
Sultan, thank you so much for your reflections. Now I think we'll be coming back to some of those themes like partnership between the sectors again in a moment. Catherine, if I may come to you, and the same two questions, both from your experience of working with health and care services, but also within health and care services, and what you heard from Jean-Frédéric. Over to you.
Thank you. I thought it might be helpful just to spend 1 minute of my 5 describing my journey over the last 5 years in trying to take technology to scale within the NHS. And then I've basically got 3 reflections of what I think local regional organisations could potentially do differently, drawing on also and complemented, I think, by what I just heard from Jean-Frédéric. So Healthy.io is a technology company using the smartphone camera as a clinical grade diagnostic device, working both in the urine testing space and in wound care. Over the last 5 years, I came into this role with my eyes open, having been inside the NHS for 15 years and then trying to work with the NHS in a large American corporate company for the subsequent 11. So this is now my 31st year at trying to transform healthcare in a variety of ways. My journey with Healthy.io, I would say, divides into a couple of years of undertaking, I think, pretty much all of those 22 organisations that you described, Malta, as supporting innovation in the NHS. So I was an NHS Innovation Accelerator Fellow. I worked alongside the AHSNs. We were part of an NHS testbed. I did an NIHR grant. I did an Innovate UK grant. We worked with PCM pilots. And I think in total, I did 16 different varieties of pilot in the first 2 years. In order to establish credibility, to kind of get our name out there, to develop proof points around usability, around the health economic case, around real world evidence, to kind of in order to actually successfully get a medtech innovation briefing through NICE. And our kind of pivotal moment of change really happened when we were selected by the Accelerated Access Collaborative to be part of their first phase of AI in Health and Social Care Award in the 4th tranche, which is about taking something from real world evidence into scale. And truthfully, without that, I don't think we would be sitting where we are today, which is that we're inside 22 ICSs. We have engaged with 332,000 NHS patients to get their kidneys screened for people who are at risk of kidney disease. And that we, have got tremendous outcomes, really, both from patients and from GP practices around how well that's going. However, it's not the final answer, because we are funded currently through the funny money that is the AAC, and we're now at the moment of trying to negotiate locally with each of the ICSs to pick up what was national funding or part national, part regional, and then to try and actually make this sustainable for the long term. And that isn't straightforward. So there are still lots of hurdles on the journey that we're on currently. The 3 areas that I think could be thought about differently by local and regional systems to try and enable this uptake and spread. One is about trust. So 2 of them are cultural and 1 of them is practical, I would say. So trust, I think, is about trust in national programs and processes. So it was variable, but generally speaking, being on the NHS Innovation Accelerator, which is a prestigious national program that is highly competitive, you know, very diligent selection of the right technologies that might have value to add to the NHS, is not then well regarded locally. It isn't understood. It isn't, you know, it isn't your immediate ticket into a kind of uptake locally. You have to really resell it at every stage. And if the amount of effort and work that the national team put into that was actually recognised locally and trusted locally, that I think would be very different for organisations like myself, who thought that was the starting point and potentially a door opener for us. I think the same is true of piloting. So the fact that you have to have a randomized control trial in my trust, and every organisation wants you to pilot before you scale, is actually exhausting for the organisations that are going through that, and just displays a lack of trust in the fact that you're not necessarily trusting your peer or your neighbour who already piloted this. And yes, you may have a slightly different population, but ultimately the differences are not that huge between individual ICSs. And then finally, really practical element around, for example, GDPR and the application of how you have to go through getting a local data protection agreement. You know, we have to go through that with every individual organisation, and then individual GP practice underneath that. There are some trusts, you know, each GDPR lead in each ICB and previously in HCCG has a different approach and a different process. And some of them take 15 to 18 months to get through the GDPR process to even get you deployed. And yet 21 other ICSs have already approved it. And it just seems a colossal waste of effort and energy from the NHS as well as for the organisation. My second is a more practical suggestion around resourcing, and this very much echoes Jean-Frédéric's notion of the toolbox of methods and the need for investment in the process of actually implementing and delivering. And I think this is something that's underestimated largely by local teams in local NHS organisations. It creates a sense of not owning collectively the commitment to actually getting something done. It actually, this concept that quite often innovators are expected to do a free pilot, which then means there's no investment at all from the kind of recipient organisation. But even in that instance, recognising in your business case that actually you need somebody to be driving and programme managing this. It's a kind of unfortunate observation, I would say, that the more control that we have as a company of what we're delivering, and in the instance of ACR, we're basically doing it all ourselves, we have much greater success than when we're partnering, where a lot of the deployment is reliant on our partners who just haven't necessarily kind of thought through the implications for their own organisation. My last observation and suggestion is relating to, again, to culture, and it's about urgency. So I think we're in a situation currently where, you know, every bit of urgency that we saw deployed through the COVID period has been recreated in terms of our challenge around resources, our challenge around workforce, the need to kind of improve on access, the need to address the kind of rising health inequalities. And yet the exhaustion post-COVID and the sort of sense of lack of investment in the service more widely, I think is leading to a kind of a even less energy than there had been previously. And it's a really difficult one to address, but sometimes when somebody does agree they want to move forward with the programme, and then it's 6 weeks before they can next get a phone call with you to talk about the next phase of the implementation, there isn't a strong sense of this type of programme being kind of driven with the urgency in delivery that I think its outcomes would merit. Final point is just, I think when Jean-Frédéric's talking about the executive partnerships that he created in New South Wales to drive change, I think we have that with ICBs. I think we're now in a situation where we've got some infrastructure here that could really help us on this journey. So I'll finish with a point of optimism that I think it's all solvable and potentially you know, achievable for the future.
Great, Catherine, thank you so much also for your 3 points at the end about the trust, the collective commitment and resourcing, and the urgency to implement at a local level. I'd like to come to Chris now, but he's disappeared from my screen. So just to check whether Chris is there. Otherwise, I will start with some questions and come back to Chris in a moment. All right, he might have dropped off. In which case, let's start with a couple of questions from me. Hopefully, we can bring Chris Lang back into the conversation, and then I'll finish off with a QA with the questions from our audience. This was one of the questions I wanted to ask you, Jean-Frédéric, and it also came up from our audience. The involvement of patients and carers in implementation. How much in your agency is that something you have systematized through a particular approach, or localized through a variety of tools? How is that being picked up in your implementation work?
Yeah, no, it's an excellent question, because it's extremely important to involve consumers and carers into both the design, co-design stages of some of those, as well as in the implementation stage. And what we've done is, one of the core function of ACI is to lead clinical networks. We've got 42 different clinical areas covered. Many of those networks have been in place for decades. They all now include consumers and consumers co-chairs of the networks. So that's one area or one way that we've systematized that. But we also have internally now a consumer team, a consumer engagement team, which is led by consumer leads themselves. And therefore, we've employed consumers to be part of our experts, supporting the design of implementation, the mobilization, and the communities of practice of consumers that are required locally to also ensure that there's a consistent involvement of consumers. We're very lucky to work with local districts that have a long history and tradition of consumer involvement as well. And many of the teams that come to our school for redesign, for example, are teams that include clinicians and at times consumers as well. So there's various ways that really we've tried to leverage to increase our consumer engagement. And about 2 years ago, we've revised our strategy for consumer engagement and innovation. And that's something that we can share with anyone interested as well.
Great, thank you so much. And Chris is back. So Chris, great show effect. Just at that moment, I took one question for Jean-Frédéric, but I'll come back to you for your reflections for the next few minutes. Thank you.
Thank you. So the UCL Partners Wi-Fi dropped at just precisely the wrong time. So fantastic talk, Jean-Frédéric, and we've been in the process of refreshing our strategy, both within UCL Partners and I think across the ecosystem via the NHS England Innovation Research Life Science Landscape Review that's going on. So I think we've much to learn from this. We're an HSN, so primarily the HSC is primary discovery and translation to the bedside, with the HSN being broader adoption across the system. And, we help our local system partners with their local data, defining problems, sourcing, implementing innovations. And we try to work between healthcare industry, charities and communities themselves, not just healthcare providers. And that sort of balanced portfolio of health and care, but mindful of how one needs some long-term strategic ambition to deliver against some of these big challenges. My local experiences, we probably need a lot more pull and a lot less push. Innovations need to be trading just not at general issues, but quite clearly defined problems. So for workforce, we're looking at automation of key processes to release capacity and so on and so on. So problem definition and a solution that's well matched to a well-defined problem is what innovators need. We need to look at the quality of the innovation itself and the resilience of the innovator who's providing it. I think the next key thing is implementation science, in which we've just really heard a masterclass. There's a big literature on this. This is a method. We need a target population. What's the benefit? What are the measures of impact? Staff engagement, resolving staff concerns or patient concerns to adoption, addressing them head on. Education, executive sponsorship, iteration, optimization locally, evaluation to make the case for further change. So I think implementation science is something we need to be using. There's the capacity in the system around data, bandwidth, of which we've heard, having those strong networks. I think probably there is a sense that this is quite diffusional and we have point sources of adoption. I think with the challenges we face, there's a need for much more strategic innovation, so large scale changes. Jean-Frederic has made the point there's only so much one can do at the same time in the same system, but we have many systems. Those partnerships need to be mutually beneficial across universities, industry and the healthcare system, trained at patient needs. But a bit less innovator driven and a bit more strategic innovation. That's teams of people coming together to solve big problems at scale and innovating in the system rather than just as a system, rather than just diffusing through it. I think leadership is important. We need system-wide plans. Sometimes the intent needs to be top down, even if there's no, this, as Catherine has said, this painful process of selling innovations from door to door. I think empowering our local systems to make decisions. I think some of our system is over-autonomized in making these decisions. We should be able to make collective decisions to do something, and we've seen great examples of that, for example, in London with the hyperacute stroke pathway. I learned a great deal from Jean-Frederic. I'd like to connect with them more, but there's some key things. Embedding innovation leads in the system, that executive sponsorship. This is an operational problem. One organizes an innovation pipeline and one needs expertise and experience to do it. The concept of long-term planning. This is going to take several years to do this. We can't be hopping around priorities with attention deficit disorder. And I think, customization according to local needs. And much to learn here. I think I'd be very grateful if you could take some of that learning into our local developments in USLP and into some of the broader thinking about how we're doing this in the NHS more widely. So very much enjoyed the talk. Thank you.
Thank you so much, Chris. I'll pick up on a couple of themes from what our speakers have been talking about, which we will begin to answer some of the questions, I hope, as well from our audience. First of all, Sultan, if I may come to you, there was a theme also around the right type of partnerships between innovator technology companies and the NHS. Catherine talked about trust. There was a question from our audience about the right way to have a partnership that means that solutions can be co-developed over time rather than bought off the shelf when they might not be quite right. From your perspective, again, with the NHS and in the NHS, what type of partnership should we aim for?
I think, as you know, the NHS is a big space, but and again, it's down to the local health economy, the local leaders to kind of decide. But I think, in terms of broad strokes, I think in terms of partnerships, I think trust is first of all the most important thing. So when we are kind of interlocking with the commercial sector will have drivers and they will have a business need. And it's incredibly difficult, as I'm finding out, to kind of go from door to door to try and make a splash. Equally, it is really frustrating on the other side, having bought quite a lot of stuff in the NHS, when people turn up and says, "I've got the best thing since sliced bread, and I understand, and would you like some?" And again, that's probably okay for a small percentage of things that we want to kind of address. I think co-creation is a really powerful tool. And I think, there are increasingly, great companies up and down across sectors, from telco to other sectors, who are working with clinicians and kind of operational management teams, researchers, innovators, and developing the use case together. That's a really powerful way to do this, because then it has validity. So made in the NHS, if you like, it has that stamp, and it has the kind of use case kind of data service evaluation data along with it. The commercial sector, for their capital investment and their resource investment, get a sense of, okay, they learn to be more customer centric, but also understand the problem in a bit more than a very superficial level. So I think there's a win-win there, and I think co-creation, it has its problems, but actually it can be a great enabler. But to do it well, it requires quite a lot of air cover on both sides of the fence. And again, the commercial entity, as well as the, if you like, the NHS organisation, will need to kind of agree a terms of reference for that. And there's this complexity, legal and otherwise, in procurement to kind of be dealt with. But I think it can be really, really powerful in solving problems. And I think some of the programs like the National Clinical Entrepreneurship Programme, some of the programs Catherine's talked about and Chris has talked about, are kind of big enablers for that. We ourselves in a big company like BT are kind of thinking through our approach. And I suppose my closest living example to this is the Vanguard program. You know, we're doing exactly what you've described, Malte. We're working with kind of partners who have asked us to kind of come in and say, right, let us kind of try and solve some of these problems together. It might be connectivity, but there are other things at play. And with your ecosystem, so you might be more helpful than you otherwise would have been. So it's that kind of approach. But it's that trust thing is so important, Malte, and that you know, Jean-Frédéric talks about kind of the long, and Chris and Catherine said this takes time, and trust is for me a verb. Yeah, you earn trust by doing stuff, and you know what you say you end up doing. And if you deviate from that, the NHS or any other sector will kind of walk away. So the commercial sector's got quite a lot of legs to go in terms of earning that level of trust needed to make this co-creation space a really viable proposition. And also the NHS has got quite a lot to learn around kind of partnering with the commercial sector to kind of make the most of it. And it's been talked about for years, you know. Wachter talked about it, didn't he, quite evocatively. But again, given the challenges, you know, 14% workforce shortages, technology, whilst it's not the panacea, can really help. Really help with that. You know, we talked about RPA and other things. We can't ignore it. So these partnerships must kind of flourish, and perhaps we need to think about what would good partnership look like in another webinar. Malte.
Great. Noted. I will definitely put that on our list. Chris, did you want to come in on this point as well? You're on mute.
It's a technical success today. So I think there's another couple of things in the mix. I think the local system leaders shouldn't underestimate the time it takes to evolve some of these innovations. It's a lifetime's work for some folks that are doing this. There's often we could do this ourselves can be a barrier. I think there's a lot of attention on commercialization of innovation from healthcare providers. The key thing is to deliver transformation and innovation, worry about the other stuff downstream. That shouldn't be the starting point. I actually had a question for Jean-Frédéric, just what population are you serving and what type of size of resource is sitting in your central agency to deliver this, which is very impressive?
Well, New South Wales is about 10 million people in population. And we have around 160 full-time equivalents in the agency, spanning the clinical engagement, system transformation, you know, redesign and implementation team, and a very strong rapid evaluation and rapid synthesis team to cover the evidence part of it. It does require an investment if you're to have enough resources and heft to be able to bring those things at scale. One quick point, Malte, if you don't mind, about the previous questions and the comments that were made is, I really feel that one of the missing link to really help innovators to find a place and to build a partnership and the mutual trust required between the public sector and the innovators is that we need to make it more explicit. What are the things that currently prevent some of the innovations from being effective and generating better value because of the way we actually organize the system right now? And then we can be more explicit about, are we willing to change those conditions so that suddenly the system is actually a fertile ground for those innovations to be successful? It's not just about adapting the innovation. You know, sometimes you need to commit to say, the system is not quite designed or resourced to help you, but we can work on this if there's a mutual benefit and a common goal, you know. But I don't think that public sector organizations have really well understood and structured that and have the right data to actually be able to understand what are the organizational impediments to the success of those ventures.
Great. Catherine, did you also want to come in on this point? And then I have a separate question for you.
just quickly talking about trust and wanting to just make the point that my point about trust was not about the public sector trusting the private sector. And I really understand why not every company is going to get trusted and adopted by the NHS. And sometimes that's for good reasons, sometimes not. Mine is more about the trust between the national and local parts of the NHS, where if the national programme has said this is an innovation to look at, and or this is something we're funding nationally because we believe in it, to then not have that isn't always taken account of by the local and regional teams who, you know, even sometimes have an antithesis to the fact it's coming from a national point of view. And secondly, that the local teams should trust their other peers around the system. So if it has been piloted in Manchester and it's gone really well, Birmingham don't need to pilot it too. They should trust Manchester. So it's actually about just creating better trust inside the organisation when something has been through a validation process, because it's totally reasonable that not every local NHS entity is going to have enough resource to make its own evaluation of every single technology that comes banging on the door. And I think, you know, that's not necessarily even good use of their time. But when others have done that, it would make more sense for that then to get adopted than to be questioned and further piloted.
Yeah, thank you, Catherine. If I may ask you one other question, which is now also coming to the questions from our audience. You mentioned the point about urgency, and some of our audience members have asked questions about the importance of organizational culture. And I was wondering, from your experience, what are some of the hallmarks of a culture or an attitude of an approach in working together and collaborating together with an entrepreneur or with a startup or a tech company from public sector that from your perspective made the difference?
It's interesting. My best example of this, I think, is from when I was actually on the client side of the NHS back in the early to mid 2000s, and I was on the receiving end of a national programme called Evercare, which was designed to evaluate whether American approaches to managed care could actually drive value in a public sector funded single government payer system. And I came at that very skeptical. You know, you have 50 million people uninsured, you've not, you spend the same amount of GDP, double the GDP that I do and get the same outcomes. Surely you Americans should be talking to me about how this process works. But actually found myself on the receiving end of a tremendous culture of quality clinicians who wore quality in their arm, but were happy to challenge other clinicians around using data to drive decision making, evaluating outliers in clinical behavior through that, holding a very clear set of outcomes that we were being held to account to deliver, recognizing if we weren't making an impact on those that we had to go back and change how we evaluated and delivered the program. It was revelatory, honestly, having been an NHS management trainee and having spent 15 years inside the service, driving what I felt was the best, you know, endeavoring to drive the best outcomes, to actually have somebody come in with that set of skills and capabilities around data, around change management, around clinical engagement. I've not yet seen that, you know, 20 years later, we've actually managed to kind of create that as a matter of course, and I think a lot of what Jean-Frédéric was talking about was the need to actually identify and resource that and then allow that to take place. And I think ultimately, coming back around in a circle, it comes back to that trust issue, that unless, you know, as Jean-Frédéric's describing it, I'm thinking, oh, well, what would a local NHS provider think about an organisation coming in to support them in this? And, you know, Chris will have first-hand experience of that with an AHSN trying to engage with its local partners. And again, there isn't always the trust there. Some AHSNs have done an amazing job on really creating themselves to be integral and engaged in the system. For others, there's a lot of sense still that it's not invented here, and who are they to tell me what I need to be doing in my organisation? And that it's just about that trust and experience of the trust. And my experience of working with this American company at the time that I ended up joining, kind of because I was so bowled over by how impressive they were, was about kind of engaging at that grassroots with all of those skill sets and really helping that culture to change.
Thank you very much, Catherine. Coming to another question, I think request from our audience. So it's actually the most upvoted point at the moment, that people would like to find out more about the toolbox that you mentioned, Jean-Frédéric, for implementation and contextualizing it. So if you wouldn't mind maybe saying a little bit more about, you know, how you go about this approach of contextualizing, and if then afterwards, Chris, I can come to you from your perspective, working locally, regionally, but also having a connection into the national approaches to implementation and prioritization. What's the right balance between the national and the regional and local in how we approach that? But Jean-Frédéric, to you first from your experience.
I mean, what's really important, and it relates to the previous point by Catherine, not every regions will be as welcoming of a central agency or a statewide program. And it's very important to ask them what is the type of support that they need. Do they need us to support them in training people so that then they've got their leads up and going and ready to implement locally almost independently from us? Do they want people to come on the ground, facilitate meetings, have co-design sessions, deliberative methods being applied, because basically they don't have the local capacity to carry on the project, and therefore they want us to carry some of the load? Do they need to learn from their peers and a community of practice kind of model to be implemented locally, so that they create the connection across the regions and across the districts, so that the support and the help comes from the side and not from the top? And there are different methods and ways we can actually support those different ways. And that's how we conceptualize the toolbox. But it really needs to start with asking them what they need. Rural regions are asking us different things than very big metropolitan centers. The local districts that have started an innovation, sometimes in partnership with innovators or others, can be brought in to actually support the implementation back with their peers as well. And that's the kind of thing that we're trying to do increasingly, to again try to pull different kinds of levers, understanding that every single regions and hospitals will have a different receptivity to different aspects. Do we still have regions saying, no, thank you, we're not interested? Yes. But I have to say that it tends to be one or two in the various programs that we have now. The majority are really coming to the table, clarifying what their needs in terms of support for implementation. And I think increasingly recognizing that we don't come with a, this is the way it's going to be, or you're not in kind of approach, and instead really ask them to tailor the kind of support that's needed. One of the things I want to say is that, for some of the programs that we've implemented, a very significant driver was the School for Redesign. And at times we have established one specific school for a specific implementation program, and every region is sending a team to the School for Redesign. And basically they are designing, building capability, planning their own implementation under our supervision. And then another team from ACI is on the ground to help them at times implement exactly what they've participated in the co-design phase. And that creates a lot of ownership locally, which I think is a significant driver of commitment to implementation afterwards. So that's just a few examples of how we conceptualize the toolbox.
Yeah, really helpful. And maybe alongside the slides that we can share after the webinar, we can also share a couple of links to some of that, yep, to the agency. Chris, coming to you on this question of what's the common approach and infrastructure, I guess, that we need at a regional level. What can be tailored further beyond that? What's the right balance, both in terms of, I guess, capability, but also approaches for that?
Yes, so I mean, I think the type of agency that Jean-Frédéric has described is quite close to the HSM, HSE function. I think what the national teams can do is at policy level make sure that things are aligning in the right direction in terms of incentives, funding, accountability, governance, and so on. And then I think there is a probably critical mass regional unit, which is maybe 3 to 10 million, depending on the complexity of the population, where we should be able to enable strategic innovation. And that's something that, I think the HSN's working with ICS and provider collaboratives with industry partners and universities can do. I think the key thing is we need to be strategic. It needs to be done in partnership, and there needs to be a methodology behind it and a real structure and expertise that is based on evidence. And I think we have heard an excellent example of that. It can be done. I think things can be done at scale, at regional level. And Jean-Frédéric mentioned the pandemic. You know, we can see what happens when incentives are aligned and people are free to work together. And I think one of the interesting things around that was there was quite a lot of locally driven innovation. It was done at quite large scale. And, you know, I don't believe in there's innovators and non-innovators. All the staff I've ever worked with are pretty innovative. And a lot of people came to the same solutions, but they were locally owned, which is a consideration. On prioritization, I don't believe there's a national, regional and hospital Venn diagram necessarily, and you do the things that overlap. I think we need to be data-driven about healthcare. You know, I think a lot of our national problems are local. It's just how they're addressed is more locally customized. There are clearly very specific regional communities that need special consideration, but I think there's an overwhelming amount of shared problems where we can align national and local thinking around early cancer, mental health, addressing health inequalities, and so on.
Great, thank you, Chris. I'm picking up another question from our audience, maybe starting with you, Catherine. The question of how, from the outset, we design in considerations of equity, equality in terms of access and use of technologies in the context of what you talked about around trust, collaboration, sort of also urgency. What's your experience of building that in from the outset?
I think the way we've approached the Minuteful Kidney deployment, you know, we were needing to be very clear we could find an approach that was going to drive health economic value to the NHS. And when you start to look at how kidney testing is done currently as part of the National Diabetes Audit through GP practices, it's very variable in terms of outcomes, in that only 50% of the population who are supposed to do the test actually do it. But those that do it, it's done in a fairly effective way in terms of, you know, somebody will take a pot of pee in when they go into their annual diabetes check, and it's sent off to the hospital, and it isn't a high cost intervention. So our kind of, the way we've ended up focusing in on inequalities was kind of ironic, because we started off by coming from what we felt was the major driver for the NHS as an outcome, which was we've got to be cost effective, we've got to show the health economic value here. So we focused in on the population that don't do the test currently, who then, as they go through the system and potentially develop chronic kidney disease because they haven't been screened, they cost a huge amount to the system, from end-stage renal disease, transplantation, dialysis. Now, by focusing in on those that don't conventionally engage in the service, we realised, of course, we're by definition engaging with people who are not otherwise kind of committed and engaged, or not otherwise finding the right kind of service for themselves in what the NHS currently offers. So what we then started to do is to drill into who are those people in terms of their social deprivation, their ethnicity. We're now seeing that the largest total uptake for the test is people in IMND1, so the most deprived, least socially kind of affluent communities. And we are now working, we had a great meeting last week with Bola Oluwabi and the team from the Health Equity group to actually, in NHS England, to try and actually unpick further what other areas are we engaging in on that basis, to see whether then that can become a hook that is as important to the NHS as the health economic piece. So it's been an interesting journey where we've actually, you know, didn't necessarily set out. And in fact, there's a lot of people who would kind of question, if you're using a smartphone as part of a digital enrollment, are you automatically excluding everybody for whom there is no smartphone? But actually what's really interesting then is that actually more people have a smartphone than you expect from those lower socioeconomic deciles, but also you're not taking away the existing service, where if you prefer to take your non-digital approach and take your sample into the practice, that still exists for you. So really interesting kind of set of issues. I think, though, that exemplar probably shows that it hasn't been the definitive starting point of the project. It's really been the kind of learning as we've gone through, and I think more approach to kind of recognizing upfront and co-creating, to Sultan's point earlier, could be really useful, because you can actually then understand that how a technology actually has some other impacts that actually are positive, that might not be where the company that was engaging in them started.
Yeah, that willingness to co-design, but also then being flexible to adapt when you actually realize the actual user needs.
And what you then need
what
to
they look
measure
like.
to actually then prove that out further, and where you have to do more research to kind of really truly understand the impact.
Yeah. What is probably our last question? It's 5 to 12. If I'll direct it at you, Sultan, there were a number of people who asked about how do we keep clinicians engaged if implementation takes a long time. It takes quite a lot of additional capacity and understanding expertise around change. How do we keep the clinician community that is so much under pressure engaged? And I guess in your previous role, you had to do that alongside them. Now you do it from the side of BT. What's your perspective on that?
It's a really important question. I think it's, of all the things we're trying to do, I think it's elemental, given clinicians are kind of the, if you think about the British Social Attitude Survey, kind of clinicians generally come out really highly, and with good reason. I think not telling stories that you can't back up. So clinicians, we're in the world where nurses are having to put obs down on bits of paper and then take it back to the nurses' station. And we're talking about building skyscrapers in the sky. So I think getting clinicians on board is really about kind of understanding their kind of pain points, on a very practical level, and then setting a trajectory, not kind of saying we're going to do this, but getting their views around what would solve this. Of Catherine gave a really great example of how a really positive intervention around kind of kidney care has had unintended positive consequences around the kind of the equality and equity space. I think engaging clinicians kind of at the outset, acknowledging their pain points, and kind of then working with them to create a suite of options, and not kind of railroading them into a particular track of thought that one might have had, saying, well, I've got good relationships with X, so I'm going to kind of put this tool in. I think that's the way to engage clinicians. I think also to make this really important, I talked about the time piece. So clinicians at the forefront of kind of change management and kind of digital change management, it's space in their work plan, very practical, job plan space to do this. And also to make this really, really kind of embedded. If you start by kind of developing a cadre of leaders, we have the Topol fellowships and other things, but within health economies, if we work on ICB, ICS levels, there's a cadre of leaders across the system. They kind of work as a kind of collegiate group of people working through a toolbox methodology, like Jean-Frédéric said. I think that could have, so kind of you've got the people incumbent now, but if you think about the next in lines being incubated, to use a digital term, across the system, that might be a way. But to show them importance in this, you can't tell them pork is malt.
Yes, indeed. So that realism and the pathway that one embarks on together to achieve that. Right. Thank you so much for all your contributions. We're nearly at 12 o'clock, so I'll wrap it up here. Thank you again so much for Jean-Frédéric from joining us from Australia, and so late in the evening. Really, really appreciated. Thank you to Catherine. Thank you to Chris. Thank you to Sultan for joining us. The webinar will be available, recording of it afterwards on our website if you'd like to watch it on demand or share it with others, colleagues who've missed it. If you'd like to receive updates on future webinars from the Health Foundation, there'll be a link in the chat shortly, and will also come up on the screen. With that, thank you so much again for joining us this morning. Have a wonderful rest of the day. Thank you so much to our panelists, and see you all soon. Thank you and bye-bye.